Bom dia. Vamos dar início ao simpósio, terceiro simpósio do Grupo Oncoclínicas. Mais especificamente, vamos dar início à sessão de câncer de mama. E antes de começar essa sessão, eu vou contar uma história para vocês, no sentido de que vocês possam entender qual é o espírito desse simpósio. Houve um simpósio há muitos anos, se não estou enganado, em Cambridge ou em Oxford, onde se reuniram vários físicos na ocasião, Niels Bohr, Einstein, Max Planck, então uma série de físicos quânticos, vários deles ganhadores de prêmio Nobel, se reuniram nesse simpósio. No final do terceiro dia do simpósio, iam debater o início do universo. Um repórter perguntou para o Dr. Niels Bohr: vocês ficaram reunidos vários dias, e qual que é a solução dos problemas, dos grandes problemas da física? Então, Niels Bohr diz o seguinte: olha, há 3 dias atrás nós chegamos aqui confusos. 3 dias depois, nós estamos mais confusos ainda, mas nós estamos confusos num nível mais elevado de sabedoria. Então, significa o seguinte: muito do que nós vamos discutir aqui são condutas e são situações que estão no limite do conhecimento médico. Então, muitas das perguntas desses simpósios vão continuar sem resposta, mas eu espero que, ao final, a gente esteja com mais dúvidas e dúvidas mais elaboradas em relação ao melhor cuidado da paciente com câncer de mama. Para iniciar o nosso simpósio, eu vou chamar o Dr. Eric Weiner, que é diretor do Centro de Oncologia e Câncer de Mama do Dana-Farber Cancer Institute e professor da Harvard Medical School, para falar para nós sobre câncer de mama nas duas últimas décadas, quais foram os avanços e quais são os desafios pela frente.
Good morning. Good morning, Otto. Thank you all very much. I want to spend the next half hour talking about where we have come over the last 20 years. And I'll start with a very brief view of where we were 20 years ago, which sadly I remember, and the progress we've made. And of course, much of this will touch on aspects that other speakers will speak about later on today. There we go. So, and can we get that monitor working or not? Does that monitor work over there so I don't have to look behind me? Just if it works, that's great. If not, I can turn around. So, in many ways, this is breast cancer now 20 years ago. And we had this view of breast cancer as one monolithic disease. So a woman would come to clinic and would say to me, what kind of breast cancer do I have? And I would say, you have stage 1 breast cancer, you have stage 2 breast cancer. But I didn't have any way of describing what kind of breast cancer she had. Although most oncologists at the time, and most surgeons and most radiation oncologists at the time recognized that breast cancer wasn't one simple disease, but we didn't even have the nomenclature to describe what was different about one woman's breast cancer from another. And perhaps the first step in that direction was this work that was done by Chuck Peru and by his colleague, Dr. Sorley, where they took a group of breast tumors and they looked at the genomic profile of these cancers and demonstrated that, in fact, that if you looked at the genes of these cancers, that they actually looked quite different from one another. This is a group of approximately 100 breast cancers. And when I bring in the vertical lines, you can see that there are patterns that emerge. But perhaps what's more striking is that these patterns actually correlate with the behavior of different subgroups of women with breast cancer. And this, in combination with examination of clinical data, led us to a view now probably about 15 years old that breast cancer is a family of diseases. A family of diseases here we go. This is probably the best way of doing it. A family of diseases that, at least when we first looked at this, seemed to be made up of several distinct family members. There were the HER2 cancers, HER2-positive cancers, and the triple-negative cancers, and at least two types of estrogen receptor-positive breast cancer, defined to some degree by how proliferative that they were. But the truth is, we don't have 4 types of breast cancer. And I don't know how many types of breast cancer we have. And in the end, it's not going to be 100,000 different types of breast cancer. It's not going to be 400 different types of breast cancer. But my best sense is that 5 years, 10 years from now, when we're talking about breast cancer, we're probably going to be talking about somewhere in the range of about 10 different distinct subtypes of breast cancer, which will have different natural histories and different approaches in terms of treatment. So what has changed? And what has changed over the last decade can really be subcategorized into three groups. First, there are the changes in HER2-positive disease, and I'll review those very briefly with you. And then there are the changes that have occurred in ER-positive and HER2-negative breast cancer. And finally, unfortunately, fewer changes, but still some promise in the setting of triple-negative breast cancer. So first, HER2-positive breast cancer, where arguably the most dramatic advances have been made. This is a cartoon from a review article written by Cliff Hudis, our colleague at Memorial Sloan Kettering, looking at some of the molecular aspects of HER2-positive breast cancer. Remember that HER2 is a member of a family of receptors, HER1 being the epidermal growth factor receptor, and HER3, which is an important player here in terms of HER2 activation, and HER4. And that activation of HER2, which can occur either by homodimerization or by heterodimerization, homodimerization referring to a HER2 and a HER2 joining together, heterodimerization, a HER2 and most commonly HER3 joining together, then leads to a complicated signal transduction pathway. And this understanding of the biology has led laboratory investigators to develop hypotheses and develop treatments in terms of where we can move forward in terms of HER2-positive breast cancer. So this is actually the first study that specifically looked at a monoclonal antibody, specifically trastuzumab, in the setting of HER2-positive breast cancer. And when this came out now about 15 years ago, I don't think that any of us would have expected that trastuzumab would have such a profound effect on the natural history of HER2-positive breast cancer. The results were impressive, but they weren't so very impressive. There was an improvement in response rate, there was an improvement in time to progression, and all of a 4-month improvement in median survival. Although there were many aspects of this trial that in fact worked against it, and why in fact the results were somewhat less impressive than ultimately I think has turned out to be the case in clinical practice. And building on this work, we have seen a series of drugs that have been developed. You're going to hear more about these drugs later on, both from me and from others, but the changes that have occurred in HER2-positive breast cancer are really quite dramatic. So this is the so-called Cleopatra trial, a trial in which women with metastatic HER2-positive breast cancer were randomized to receive either chemotherapy, in this case docetaxel plus trastuzumab, or that same chemotherapy regimen plus pertuzumab. And as you can see, there was a striking improvement in terms of overall survival in this study. That improvement, of course, was accompanied by an improvement in progression-free survival and an improvement in response. But this degree of improvement in terms of survival is what was particularly noteworthy. And it's noteworthy, again, a 16-month improvement in survival, particularly because the pertuzumab was stopped at the time that patients developed disease progression. The difference in median time to progression was 6 months. So in fact, on average, patients received about 6 months more of pertuzumab, on average, patients had their disease controlled for 6 months longer with pertuzumab. But in spite of that, that same group of patients whose pertuzumab was stopped when the disease progressed lived 16 months longer. And what that suggests is that the administration of pertuzumab early in the course of the disease ultimately led to some fundamental change in the disease and led to how patients actually did after pertuzumab was stopped. Now, pertuzumab is not the only drug that was developed or has been developed for patients with HER2-positive breast cancer. And the drug T-DM1, which is an antibody-drug conjugate, has also been developed. This has been compared with capecitabine and lapatinib, which for many years was a standard that none of us liked very much because it was so toxic. And in fact, what has been demonstrated now in comparison with capecitabine and lapatinib, and what we'll hear more about other studies with T-DM1 at the San Antonio meeting, but here again, an improvement in overall survival. And we now talk about these new drugs that give overall survival benefit. And remember that for 10 years, 20 years, we would all go to meetings over and over and over again. We would hear about small improvements with drug therapy and would never hear about differences in overall survival. Now, these improvements that have been seen in the metastatic setting for HER2-positive breast cancer have also translated into improvements in the adjuvant setting as well. These data are from one of the initial adjuvant trials that was conducted, a trial that compared chemotherapy alone or chemotherapy plus trastuzumab in women with stage 2 and stage 3 HER2-positive breast cancer. And what you can see in this recent paper from Edith Perez is the long-term follow-up from this study with a persistent, roughly 10% improvement in both disease-free survival and in overall survival with the inclusion of a year of trastuzumab. Unfortunately, not all studies that have looked at HER2-positive breast cancer and have looked at the inclusion of additional therapies have been positive. And in fact, just in the last year and a half, we've learned that the ALTO study, a study that added lapatinib to trastuzumab, a study that was based, and we'll talk about this later on strong work in the neoadjuvant setting, but this study failed to show an improvement by adding lapatinib to trastuzumab and resulted in additional toxicity without additional benefit. And although some people looked at the results of this study and said, 8,000 patients on a study like this, what a waste. In fact, it wasn't a waste at all because it demonstrated that a drug that could have been used based on smaller studies in this setting simply wasn't effective. Nonetheless, we're waiting for results from the Affinity trial, a trial which has incorporated pertuzumab with trastuzumab. There are many people who are very hopeful about this approach, largely because of the very dramatic survival benefit that I showed you just a few minutes ago. And finally, before leaving the area of HER2-positive breast cancer, I think there's another very important lesson to take away here, and it is that not everybody needs more drugs. And even if it turns out that the Affinity study is a positive study, and even if it turns out that adding pertuzumab improves the percentage or increases the number of the percentage of patients who remain disease-free by 3% or 4% or 5% or 8%, it doesn't mean that absolutely everyone has to receive that kind of approach. And these are results from a large phase 2 trial that was led by my colleague Sarah Tallaney at Dana-Farber, done in multiple centers across the United States, where in fact we took patients with stage 1 HER2-positive breast cancer, a group of women who at the time were routinely receiving trastuzumab, typically trastuzumab with moderately toxic chemotherapy. And we said, is it possible to give them a simpler chemotherapy regimen? And what we did was we gave these women a year of trastuzumab and 12 weeks of paclitaxel only, no anthracycline, no carboplatin. And what we demonstrated was that the 3-year disease-free survival was between 98 and 99%. Now, you can argue whether some of these women might have done fine, and undoubtedly many of them would have, with no adjuvant therapy. But what you can't argue with is that another treatment would have been better, because this result is simply so very favorable. So let's move on and talk about another area where there has also been a great deal of progress made, somewhat different progress than has been seen in HER2-positive breast cancer, and that's in patients who have ER-positive, HER2-negative disease, which is, of course, the most common subtype of breast cancer, represents about 70% of all breast cancer. And here, over the last 20 years, I think we've learned, among other aspects, we've learned that there's a fundamental difference in the biology of ER-positive, HER2-negative disease than from, for example, HER2-positive disease or triple-negative disease. And some of that difference is reflected on these curves here, where we've learned that the pattern of recurrence is very different for these patients. Patients with triple-negative disease, and to some extent with HER2-positive disease, when they're going to develop recurrent disease, develop that recurrent disease in the first 5 years. In contrast, what you can see here is that for patients who have ER-positive breast cancer, that in fact the risk of recurrence is lower in the first several years, but persists for many, many years thereafter, such that patients with ER-positive and HER2-negative disease are at risk for recurrence at years 5 and 10 and 15 and 20, and these are the patients who in all of your practices you see are occasionally developing breast cancer recurrences at year 20 and 25. We've also learned through analysis of older data that in fact chemotherapy, while it on average is beneficial for patients with ER-positive, HER2-negative disease, is actually only beneficial in eliminating early recurrence. So if you look at curves, and this is from the Oxford overview of patients who received chemotherapy versus those who didn't, there is a benefit for chemotherapy, a benefit that probably is limited to a small subgroup of patients, but which is seen when you look at larger groups of patients, but a benefit that only exists in the first 5 years. Now that benefit persists beyond 5 years, but the curves do not continue to separate. And what that means is that if you have a patient with ER-positive, HER2-negative breast cancer who you didn't give chemotherapy to, and she's 8 years out, you can look at her and you can tell her there would not have been any benefit from chemotherapy because it only prevents early recurrence of disease. What prevents late recurrence of disease? Well, as best we understand, the treatment that is most effective here is the prolongation of endocrine therapy, although we're still struggling with who needs prolonged endocrine therapy and what that prolonged endocrine therapy should look like. This is from Paul Goss's MA17 trial, in which they took patients who received 5 years of tamoxifen and randomized them to letrozole or to a placebo, and demonstrated that in each and every year after 5 years there was benefit in the women who received letrozole versus those who received a placebo, but a benefit that manifested itself in terms of an improvement in disease-free and overall survival only in node-positive patients. And we still have many, many questions about extended endocrine therapy. We've seen benefits with an AI after tamoxifen. We've seen benefits with tamoxifen after tamoxifen, so 10 years of tamoxifen is better than 5 years. We still don't know what to do in a woman who's had 5 years of an aromatase inhibitor. We have not demonstrated that longer duration aromatase inhibitor therapy is better. We don't know that it's safe, and we don't know that it's effective, and we have trials that are pending. And perhaps most important, we don't know which patients really benefit from this approach, which of course is a theme that comes out over and over again in the adjuvant setting. There are some initial clues here, and this is work from Jack Cusick and from others, suggesting that what predicts for risk of late recurrence is actually the same thing that predicts for risk of early recurrence, and that is luminal B versus luminal A status, so these tumors that tend to be somewhat more highly proliferative, and that these are the cancers that seem to more commonly recur in years 8 and years 10 and years 12, and one can only then extrapolate that these may be the patients who benefit the most from prolonged endocrine therapy, but we still have many questions. And then, of course, the other big question is who really needs chemotherapy? In fact, it used to be the question, who can do well without chemotherapy? I think the question is now, which patients with ER-positive breast cancer actually should get chemotherapy, and that our norm should increasingly be not to give chemotherapy, with the idea that some patients benefit more than others. Or benefit, whereas others simply don't. These are data from Oncotype DX, and this is looking at Oncotype DX in the context of NSABP B14, an old trial that randomized patients to tamoxifen or not in the adjuvant setting. And what it demonstrates is that not only is the score from the recurrence score, or the Oncotype DX assay, not only is that associated with the risk of distant recurrence at 10 years, but that fully half of these patients with node-negative ER-positive breast cancer fall within the low-risk group, a group of women who have less than a 7% chance of distant recurrence through 10 years of follow-up. And what has been further shown, specifically with the recurrence score, we haven't shown it with other genomic assays, although my guess is that this holds true with other genomic assays, we simply don't know that at this point in time, is that the score on the assay is also predictive of the benefits of chemotherapy, such that patients who have low scores not only are at low risk of disease recurrence, but in fact that the benefits of chemotherapy there are very, very limited or non-existent. And it's the patients whose cancers are more likely to recur where, in fact, we get a benefit associated with chemotherapy. We recently received some results from the so-called TAILOR-X study. TAILOR-X is a trial that took patients and performed one of these recurrence scores, or an Oncotype DX assay. For patients who had a score of between 11 and 25, there was a randomization to chemotherapy or not, and we don't know the results of that yet. But for patients who had scores of less than 11, those patients were assigned to endocrine therapy only. And what was reported first at ESMO and then published in the New England Journal within the last 2 months is that these patients had about a 1% chance of distant recurrence through 5 years with endocrine therapy only. A very, very favorable prognosis, clearly indicating that you can't do much better. Perhaps some of these patients are the patients who increasingly, we believe, might never need any therapy for their breast cancer. We don't know that yet. But clearly, these are patients who one could look at and say, breast cancer is not going to interfere with your life. And the big question here is the benefit of chemotherapy in patients with scores between 11 and 25. Given the results in the patients below 11, I think we can be pretty certain that the results in patients, for example, who have scores between 11 and 18 or 20 are almost certainly going to show us that chemotherapy isn't very beneficial. And finally, before leaving this area of ER-positive breast cancer, just a comment about the SOFT trial. The SOFT trial came out in the past roughly year. And the SOFT trial was done in premenopausal women and randomized women to ovarian suppression or not. And if a woman received ovarian suppression, she received an aromatase inhibitor or tamoxifen. And although the SOFT trial overall was in fact a negative trial, if you look at the entire study population, there was not a statistically significant benefit for the addition of ovarian suppression to tamoxifen. What has emerged, however, are findings from individual subgroups that are actually quite interesting. And so first, there's the large subgroup in SOFT where no chemotherapy was administered. These are patients who, generally speaking, had stage 1 breast cancer, all of whom, of course, were premenopausal. Most of these cancers were low to intermediate grade. And what has been demonstrated is that these patients actually had a strikingly small number of events, no matter what treatment they received, suggesting that we were identifying a group of patients not dissimilar from the patients identified in the Taylor-X study, but patients who had an excellent outcome with endocrine therapy, here specifically tamoxifen alone. In contrast, there was a group of patients, typically patients who received chemotherapy, typically patients who were younger in that premenopausal range, where there was a big benefit associated with ovarian suppression. And this is very much an area where we're still trying to work out the rules at our tumor board, as well as at, I suspect, all of your tumor boards. We discuss at great length which patients should have ovarian suppression, which patients shouldn't, and partially because the studies were simply not large enough, we don't always have a clear sense in an individual patient how great the benefit of this treatment is going to be. And for a premenopausal woman to go on ovarian suppression or to have her ovaries removed, while it is an endocrine therapy, it is by no means a therapy that doesn't have a moderate amount of toxicity for some patients. And finally, in terms of ER-positive breast cancer, we've seen 2 additional changes, and that is the development of targeted therapies. We've seen in the metastatic setting the development of the mTOR inhibitor, everolimus, which in fact is approved in the US. I don't know whether it's approved in Brazil or not, but a treatment that has improved progression-free survival, albeit not overall survival, and a treatment that has a fair amount of toxicity, leading most of us to be pretty cautious about the use of this agent, although it is being looked at in the adjuvant setting. And then there's been greater enthusiasm for the CDK4/6 inhibitors. There are 3 of these inhibitors that are presently in development. The one that is approved in the United States is the drug called palbociclib. These agents enhance the benefits seen with endocrine therapy by interrupting the cell cycle. And in both a randomized phase 2 and in a phase 3 trial, the drug palbociclib has shown to be superior to endocrine therapy alone, and what is called the PALACE trial is being conducted worldwide to look at the benefits of this agent in the adjuvant setting. So finally, triple-negative breast cancer, and unfortunately here the progress has been more limited, and it's not going to take me long to go through it. We've learned in triple-negative breast cancer that all triple-negative breast cancer is not simply the same thing. It's not simply triple-negative breast cancer. That there seem to be some very distinct subtypes of triple-negative breast cancer listed on the side of this slide, and that those subtypes of triple-negative breast cancer may require different therapeutic approaches. We've also learned about one old drug and one set of new drugs. First, the old drug, and that old drug is carboplatin, or for that matter, cisplatin, either of the platinum agents. There was hope that these drugs would turn out for all patients with triple-negative breast cancer to be particularly effective drugs. And at least in the metastatic setting, the TNT trial, which was presented at San Antonio last year, has demonstrated that carboplatin is about as good as docetaxel, but no better. But what has emerged is a relationship between BRCA status and the benefits of platinum. And in particular, what has been shown is that not that docetaxel is ineffective in patients with BRCA mutations, but that platinum is particularly effective. So this is looking at platinum in patients with mutations and without mutations. And here you can see that those patients with mutations had a longer progression-free survival, and that longer progression-free survival arises because there is a significant interaction between BRCA status and what treatment was given in this study. Specifically, patients who received platinum and had a BRCA mutation had a particularly favorable outcome. And then finally, there are the PARP inhibitors. The PARP inhibitors work by impairing repair of single-strand DNA breaks, which becomes increasingly important in the context of a tumor with a double-strand DNA, with an inability to repair double-strand DNA breaks. And what's been seen with the PARP inhibitors is that these agents are clearly active in patients who have BRCA-associated breast cancer, and there are randomized trials that are now going on looking at the PARP inhibitors versus chemotherapy in patients with BRCA-associated breast cancer. And finally, just to wrap this up, a little taste of the future. So the TCGA has examined the genome of hundreds and hundreds of breast tumors. To date, there's been relatively little work correlating these data with clinical factors. But what has emerged is a landscape of the genomic alterations seen in breast cancer. And we're beginning to get clues about different alterations seen in different subgroups of patients. The two most common alterations that have been seen to date are one that we can do something relatively little about, which are p53 alterations, and then PI3 kinase alterations, or specifically mutations in PIK3CA. And there is hope that that will be a genomic change that can in fact be targeted. But there are a whole range of different genomic abnormalities that are seen in breast tumors that have the potential to be targeted with the new generation of targeted treatments that we have. Of course, designing the right trials to address the right questions for these patients is by no means a simple exercise. And finally, all of this arises within the context of what are truly staggering costs of cancer care. And it used to be that the rest of the world perceived the United States as being on some island where cost didn't matter, and it mattered for everybody else. And now cost matters for us, it matters for you. It's a big problem when we think about how to deliver care to the hundreds of thousands of women with breast cancer who develop it each year, not to mention all of the other cancers. These are US costs for drug only. We're not even talking about administration. We're not talking about supportive care. We're talking about buying the infusion or the pill itself. So where are we in 2025? Well, the four subtypes that we've become familiar with will become some larger number. There are many more targeted therapies that will become available in the years ahead. Some of them will replace some of our standard therapies. Others will be added to our standard therapies. Sorry, I got to keep turning around. Immunotherapy, which I haven't touched on, and for which, you've heard more and more about immunotherapy over the past year or two, largely in other diseases, is moving into breast cancer. Be ready. We're going to hear a lot more about immunotherapy in the next few years, and it almost certainly will play a major role. Surgery, I'm sure there are surgeons in the audience, will remain important. Our next speaker is a surgeon. But the role of surgery is going to continue to evolve, and our surgical colleagues have continued to ask questions of how they can do less and less to enhance quality of life for the patients we take care of with early stage disease. We're going to hear later today about preoperative therapy in greater detail. I think we're going to see this used more and more as a tool to explore new therapies. And finally, women will live longer with metastatic breast cancer in the years ahead, and deaths will decline. But we still have many challenges. Drug resistance is a big problem that we continue to have to work on. Overtreatment remains an issue, and it's not just about figuring out who needs more, but as I've said, who needs less or who needs different. The genomic era and targeted therapy offer great hope, but there are going to be complex trials that we have to define. Disparities are a problem not just in the US by any means, but particularly when we look at this worldwide, and the cost of cancer care is truly staggering. And finally, we have to remember that this is within the context of the entire world, where in fact breast cancer affects more than 1 million women a year, and there are over 450,000 deaths from breast cancer that occur across the globe every year. So this is a major problem that we need to tackle. Thanks very much.
Vamos dar continuidade. Nós vamos iniciar agora o módulo de tratamento loco-regional, baseado em casos clínicos, e eu vou pedir o Dr. Silvio Blomberg para vir coordenar a mesa.
Bom dia a todos. Eu sou Silvio Blomberg, eu sou cirurgião mastologista, trabalho no Hospital Israelita Albert Einstein, na Escola Paulista de Medicina, e eu queria agradecer o grupo da Oncoclínicas pelo convite de coordenar esse módulo. Eu queria chamar inicialmente os debatedores, que é o meu amigo Carlos Chimizo, radiologista do HC, e o Dr. Antônio Carlos Jardim, que serão os debatedores desse módulo. Então, só para corrigir, eu não tinha os predicados. Então, o Dr. Antônio Carlos Jardim é professor da UERJ, é cirurgião também, e o Carlos Chimizo também é do Grupo Fleury. Tá? Enfim, o palestrante será o Dr. Mera Goshen, que vai falar para a gente um pouquinho sobre a cirurgia redutora de risco. Será que a cirurgia redutora de risco tem indicação em qualquer idade? Será que a salpingoforectomia ainda ela é vista como protetora para as pacientes que têm a mutação BRCA1? Enfim, ele vai tentar elucidar para a gente. Por favor, Dr. Mera.
good morning, and I'd like to thank Oncoclínicas São Paulo for the kind invitation to come back, Bruno and Eduardo and Gilberto and the many others who have been so very kind to us and wonderful hosts. And I think, as Eric mentioned, maybe this will be my last opportunity, since surgery is going to have more of a limited role, to come and give talks about surgery, and I'll look at a different career. What they want me to discuss today, which I found was actually a pretty fascinating topic, was on risk-reducing surgery and whether there's an improvement in overall survival. And I can see where these monitors are a little bit of a challenge. What I'm going to do is go over BRCA mutation estimated overall risks. What are the risk-reducing strategies, both surgical and non-surgical? Touch base a little bit on survival data and some patient centered decision making. So this cannot sit alone as a surgery issue. This works with medical oncologists, our breast imagers, our reconstructive surgeons, and our gynecology oncologists. And the role of each of these modalities in terms of making decisions that are appropriate for patients who are at high risk of developing breast cancer through a BRCA mutation. And again, I'm going to focus more on those who do not have a cancer diagnosis and whether there is risk-reducing benefit, and specifically if there's a survival benefit. So we know that BRCA mutation by itself has a higher risk of developing cancer more than any other entity, whether that's atypical hyperplasia or even those that have had mantle radiation. And I think, even though with panel testing that these numbers will probably end up changing, that BRCA1 and 2 mutations will continue to occupy the vast majority of those patients who have hereditary predispositions to breast and ovarian cancer. And the risk-reducing strategies, we know that for breast cancer, that the risk of developing breast cancer by the age of 70 reaches up to 90% as opposed to 8% in the general population. And then if you look at the risk of ovarian cancer, that number is 44% to less than 1%. And when you look at that risk of developing a second cancer with those who have a hereditary predisposition to breast and ovarian cancer, that number is as high as 27% for those with a BRCA mutation, and ovarian cancer risk within 10 years of a breast cancer diagnosis could be as high as 13% with those who have a hereditary predisposition to under 1% to those who do not. And in terms of surveillance, well, we use a strategy of self-examination, clinical breast exam, mammography, and in the US, a combination of tomosynthesis and digital mammography, and we like alternating with breast MRI, usually at least a 1.5 Tesla MRI every 6 months, and with ovarian cancer, pelvic exam, and the data not as strong, but with transvaginal ultrasound and CA-125 testing, especially if a patient does not choose risk-reducing strategy. In terms of surgical management, breast cancer risk reduction with those who undergo risk-reducing bilateral mastectomy will be over 90%. With oophorectomy, that number could be as high as a 70% risk reduction for breast cancer and as high as 97% for ovarian cancer. In terms of non-surgical strategies at looking at these patients, oral contraceptives, use for those with a BRCA mutation for ovarian cancer, certainly there is a risk reduction associated with that group. It's a little bit more contradictory and really not one way or the other for breast cancer risk. And then if you use tamoxifen for risk reducing for contralateral cancer for those that are at high risk is a 50%. But when you look at those for risk reduction for those for primary breast cancer in a high-risk population, it's been reported as high as 45%, but they really didn't stratify or report the specific numbers of those who have a BRCA mutation. In terms of histology, and this was gone over in the previous talk with the BRCA1 carriers, this is more of a surgical basal-like or triple-negative breast cancer, and then the BRCA2 mutation carriers, it tends to take on the phenotype of the general population of those who do not have or who have sporadic breast cancers. I think DCIS does play a role in those who have hereditary predisposition to breast and ovarian cancer, and the risk of someone just de novo with DCIS by itself having breast cancer, that number is low, about 3% overall. The strongest data that comes on risk-reducing surgery and survival is with risk-reducing salpingo-oophorectomy, and that comes from Domchek's group, and that risk reduction was seen both for breast and ovarian cancer when they underwent bilateral salpingo-oophorectomy in terms of overall mortality risk reduction. And if you look at the absolute numbers at 5 years, that again, that risk reduction was seen for both breast cancer specific survival and overall cancer, ovarian cancer specific survival. They didn't show the same with risk reducing mastectomy of the nearly 2,500 patients, and I don't know what happened to the font on the top because it doesn't look like that on my Apple computer. The risk reducing strategy with bilateral mastectomies, no patients ended up developing breast cancer. But those who underwent risk-reducing mastectomy did not undergo risk-reducing mastectomy and only had surveillance only. 100 patients developed breast cancer. There was not enough data to report survival benefit for breast cancer-specific survival or overall survival for those who underwent prophylactic mastectomy. And if you look at the oophorectomy in terms of diagnosis of a first breast cancer, that reduction was 20 to 14%. It was a little bit more strong than those with a BRCA mutation of BRCA2 from 23% down to 7%. And the risk reduced for overall breast cancer mortality, the absolute benefit was 4%. Another study, this one coming from the Mayo Clinic, just looking at a high-risk cohort with a small number of BRCA mutation patients that undergoing bilateral risk-reducing mastectomy, that none of the patients ended up developing breast cancer at 13 years. Again, suggesting that bilateral mastectomy will reduce your risk of developing breast cancer, which makes sense, but so far not data suggesting that there would be a survival benefit. Another study looking at Meyer-Heber looked at bilateral risk-reducing mastectomy versus those that didn't specific, not just to the high-risk population, but to the BRCA mutation carriers. And again, if you underwent risk-reducing mastectomy, none of these patients ended up developing breast cancer, as opposed to 17% who just underwent surveillance at 5 years. This comes from the surgical group in Rome, a meta-analysis of 4 trials of BRCA1 and 2 carriers looking at various risk-reducing strategies of both bilateral mastectomy and or oophorectomy. They looked at 4 trials, and breast cancer incidence reduction with risk-reducing surgery of mastectomy was 90%. It was also similar in those patients who did not undergo previous oophorectomies in terms of the magnitude of risk reduction. In this slide, you look at the overall population of BRCA mutation carriers undergoing risk-reducing surgery with mastectomy alone. Again, an over 93% risk reduction. If you remove those patients who underwent salpingo-oophorectomy, that risk reduction still stayed in place. And then this is the group that had both breast-reducing risk surgery with mastectomy and oophorectomy. Looking at a more of a population-based study, Sarah Ingham looking at the Manchester genetic medicine database of nearly 700 gene mutation carriers, and looking at overall risk reduction with bilateral mastectomy, that risk-reducing surgery had higher survival when you did both bilateral risk-reducing mastectomy and oophorectomy as opposed to one strategy alone. What they found was that the majority of deaths was due to breast and ovarian cancer, which makes sense, and that the risk reduction mortality benefit was not seen in the mastectomy group alone, but they suggested potentially with longer term follow-up that this may end up translating into a survival benefit. This looks at their Kaplan-Meier curves of using risk-reducing surgery of either bilateral mastectomy and or salpingo-oophorectomy compared to those that had no risk-reducing surgery at all, and that risk reduction was present. And then the lower plot looks at risk-reducing surgery versus those that were screened, and the same thing was shown. This study comes from Evans, also from the Manchester group, and looked at 105 patients with a BRCA mutation controlled with 600 BRCA mutation carriers who did not undergo risk-reducing mastectomy. And the risk of developing, and this is for those who underwent contralateral risk-reducing mastectomy at 10 years, that the survival benefit was 90% as opposed to 70% in the group that did not, and that this survival advantage remained after matching for oophorectomy, grade, and stage of disease. I think in kind of counterpoint to this came from the Dana-Farber group, from Deb Schrag and Jane Weeks, looking at a decision analysis in terms of the evaluation of the role of prophylactic mastectomy or oophorectomy, and they went through 9 different intervention strategies ranging from undergoing both procedures to delayed procedures to those that did not undergo any form of risk-reducing surgery. And in their data, they suggested that the average survival benefit from mastectomy would be anywhere between 3 to 5 years. And when they looked at those for undergoing oophorectomy, that number was 1 year. And that any of the survival advantage that would be gained would be seen in patients younger than the age of 60. And they also suggested that women at the age of 30 can delay undergoing prophylactic oophorectomy for about a decade with minimal effect on life expectancy. They suggested that both risk-reducing strategies would increase life expectancy, but unlike the data that has been published to date, they suggested that that effect would be higher with mastectomy as opposed to oophorectomy alone. So I think what you can conclude is that the majority of the deaths in this population is obviously with breast and ovarian cancer, and that risk-reducing mastectomy will certainly reduce your risk of developing breast cancer. And I think this is, to me, was a little bit surprising that overall there's a lack of data on mortality reduction with mastectomy alone, but the combination of mastectomy and oophorectomy improved patient survival. Oophorectomy alone improves patient survival. And that when you look at a patient who undergoes risk-reducing mastectomy alone, that survival benefit, that risk-reducing benefit for mastectomy of developing breast cancer is well over 90%. And I think if you take away those patients who underwent subcutaneous mastectomies, in some of the older studies, that number is probably close to 100%, that risk-reducing developing breast cancer with risk-reducing oophorectomy, that number is anywhere between 45 and 60%. So that risk-reducing oophorectomy alone cannot and does not reduce the risk of developing breast cancer to the same degree as undergoing bilateral mastectomy. And that if you are going to undergo risk-reducing oophorectomy, that benefit for those for breast cancer development is if it occurs before the age of 50. And again, not to put surgeons quite out of business yet, and hopefully in a few years, even with these better therapies, that we'll still be invited to come back and talk, because I think that surgical outcomes in terms of our technique, those patients being able to offer nipple-sparing mastectomies in the appropriate patient with immediate implant-based reconstruction, our perforator programs for a certain subset of patients, are really enhancing the patient outcome. So those patients who decide to go down the route of risk-reducing surgery will end up having much better quality of life, and you can discuss the benefits in terms of risk reductions in terms of breast cancer development, but you really can't say for sure that there is going to be a benefit in breast cancer mortality reduction, even in this super high-risk group with just risk-reducing surgery alone. And with that, I'd like to thank you for the privilege of the podium, and I'm happy afterwards to answer any questions. Thank you.
Para falar agora sobre ressonância, enfim, queria chamar a doutora Terry King, please.
Good morning. It's a pleasure to be here with you today. I'd like to thank the organizers for the opportunity to come to Brazil. It's my first time, and it's lovely. So I'm going to step to the side here so that I can see this monitor in front of me. So this morning I'm going to talk about breast MRI. There's a lot of data out there, and we'll talk about when it's useful and when it's not. So I'm going to start with a sort of average patient from my practice. This is a 54-year-old female who presented for routine screening mammography. She was found to have an abnormality in the lower outer quadrant of the left breast. An ultrasound was performed to look at this area, demonstrating a 1.2 centimeter hypoechoic mass, and an ultrasound-guided core biopsy was performed, demonstrating a well-differentiated grade 1 infiltrating duct carcinoma. And so this patient has had what we would consider the essential imaging for a breast cancer patient. She had good quality screening mammogram followed by diagnostic imaging. She had a targeted breast ultrasound, which we know is critical for evaluation of masses, asymmetry, or distortion. And these are the standard guidelines that have been in place in the United States since the mid to late 90s. But more and more frequently, we're being asked, does this patient need an MRI? And in fact, our patients come in asking, do I need an MRI? And so, of course, we know there are some theoretical advantages of using MRI in the preoperative setting. There's a large body of data showing us that MRI detects additional foci of disease in about a third of patients. We know that surgical management has changed in approximately 10 to 15% of these patients. There's some evidence that MRI predicts the size and extent of the disease more accurately, and we know that contralateral disease will be identified in a small percentage of patients. Now, I did not recommend an MRI. However, she went and got a second opinion, and she did receive an MRI. So the MRI shows the known focus of cancer in the left breast at 5 o'clock. The MRI also shows another area in the left breast at 11 o'clock that undergoes a second local ultrasound and ultimately an ultrasound-guided biopsy at this outside hospital, and this biopsy demonstrates lobular carcinoma in situ. The MRI also identifies a lesion in the contralateral breast. This was not visible on ultrasound, so now she has an MRI-guided biopsy, and this demonstrates stromal fibrosis. So here's the reality of breast MRI in the preoperative setting. This patient now required additional imaging, biopsies, delaying her therapy, and certainly increasing the cost of taking care of her breast cancer. She had a false positive on the right, so now many places would be recommending a 6-month follow-up right MRI biopsy. She may require now a surgical excision for the LCIS on the left side, which we know is associated with the low cancer yield, but can have an impact on her cosmesis. And no contralateral disease was identified. So one could really ask, did this MRI actually help this patient? But this just should not be surprising to us. We have a large body of data telling us that MRI does not improve patient selection for local therapy. COMAS was the first prospective randomized trial demonstrating this, that the addition of MRI to conventional assessment did not reduce the rate of repeat operations or mastectomies. This was consistent with a meta-analysis of 19 non-randomized studies using MRI in the preoperative setting, all showing that MRI leads to more surgery, and much of which is potentially avoidable. We have another large meta-analysis of 9 studies looking at short-term surgical outcomes. This includes over 3,000 women in the preoperative setting, and again, the conclusion is that MRI increases the mastectomy rate. Now, there was a little hint in this study that MRI may lead to decreased re-excision rates in women with infiltrating lobular carcinoma, but again, this was at the expense of increased upfront mastectomies. And finally, now we actually have individual person-level data combined in this meta-analysis looking at long-term outcomes. This is 4 studies, again, over 3,000 women, looking at both local recurrence-free survival and distant recurrence-free survival. And it should come to no surprise that MRI did not affect either of these long-term outcomes. At 8 years, the rates of local recurrence in both patients with and without preoperative MRI are quite low, in the 2 to 3% range, and of course, no impact on distant recurrence-free survival based on the use of MRI. In multivariate analysis of this data set, preoperative MRI was not associated with local recurrence, but the factors that we're used to considering, such as patient age, tumor grade, margin status, and ER status, these were associated with the risk of local recurrence. And finally, on multivariate modeling for distant recurrence, again, MRI was not a predictive variable. But we do know that MRI increases the likelihood not only of more mastectomies for the index cancer, but MRI also increases the likelihood that our patients will choose contralateral prophylactic mastectomy. This is a data set that I published when I was at Memorial Sloan Kettering, almost 3,000 patients with unilateral breast cancer treated from 1997 to 2005. 14% of them underwent contralateral prophylactic mastectomy, and on multivariate modeling, the use of MRI at diagnosis was in fact the strongest factor associated with the woman's decision to undergo contralateral prophylactic mastectomy. And we see this trend even in our older patients. This is the Medicare population, so by definition greater than age 67. And we see that as MRI use increased in this population from 2000 to 2009, the rate of CPM also increased in this population. And the use of MRI in the preoperative setting was associated with 2.5 times increased likelihood that these older patients would also pursue contralateral prophylactic mastectomy. So despite the facts, the increasing use of MRI continues. This is a review of commercial insurance company claims. Over 50,000 patients under the age of 65 treated for stage 0 to 3 breast cancer. And we see that in 2005, MRI was used in approximately 20% of cases, and this increased up to 50% in 2008. So we really need to ask ourselves, who should be having a preoperative MRI? And these are my general thoughts. I use preoperative MRI in patients who are at substantially increased risk of contralateral breast cancer, and I use MRI in other specific clinical scenarios. Occult primary breast cancer, patients who have discordant or complex imaging where you need MRI for problem solving, patients who have Paget's disease who are interested in breast conservation, MRI may be helpful to detect the underlying primary, and in neoadjuvant chemotherapy patients that you're trying to downstage for breast conservation, here MRI may be helpful in selecting patients. But let's first start with patients at increased risk of contralateral breast cancer. So we know that this risk is variable, but there are subsets of patients who are at substantially increased risk. These include our BRCA mutation carriers that Dr. Golshin just spoke of, and those patients that have a history of prior mantle radiation. But there are many other factors that affect a woman's risk of contralateral breast cancer, including age at diagnosis, her family history, and the molecular markers of her primary tumor, the ER and the HER2 status. The good news is that most of our patients are not at increased risk of contralateral breast cancer. These are SEER data showing that in the United States, the incidence of contralateral breast cancer has actually gradually decreased since 1985, such that now the annual hazard for contralateral breast cancer after treatment is about 0.3 to 0.5% per year. So over 10 years, the average woman treated for an index breast cancer has approximately a 3 to 5% chance of developing a contralateral breast cancer. From the same data set, we see how these rates are impacted by whether the index cancer is ER positive or ER negative, and here it's also broken down by age. So you can see that for women with ER positive breast cancer, that the annual hazard for contralateral breast cancer actually ranges from 0.2% per year in the older patient sets to 0.4% per year in the younger patient subsets. And for the ER patients with ER negative index breast cancer, again, we see a range of a little bit higher numbers, but still less than 1% per year, ranging from 0.6% per year in the older patient subsets and right at about 1% per year in the younger patient groups. And we certainly know that anti-HER2 therapy in HER2 positive disease also decreases rates of contralateral breast cancer, and plain old-fashioned systemic chemotherapy decreases rates of contralateral breast cancer. So again, the good news is that most of our patients are not at increased risk. And this is in contrast to what we know about our BRCA mutation carriers. This is an early study from 2004 showing that at 10 years, the risk of contralateral breast cancer in this patient subset hovers around 30 to 40%. But we now have more data demonstrating that, again, we don't necessarily need a one-size-fits-all approach, even for those at highest risk. Here, the risk is broken out by whether patients have a BRCA1 mutation on the left or BRCA2 mutation on the right. And here we see that where the impact of age comes in, even in this group. So the youngest patients, those diagnosed before the age of 40, are represented in the blue line. And you can see that at about 20 years after their index cancer, their rates of contralateral breast cancer are substantial in the 60% range. But patients who are diagnosed later in age, those diagnosed after the age of 50, their rates of contralateral breast cancer, although higher than the average population, don't significantly increase until about 20 years later, when the risk is about 20%. And this is also shown in a subsequent data set by Metcalf at the bottom of the slide. Again, risk increases over time for both BRCA1 and BRCA2 mutation carriers, but this risk is actually most substantial for those who are diagnosed under the age of 50. We also know that family history impacts the risk of contralateral breast cancer in BRCA mutation carriers. Shown here, this is again most notable for those diagnosed at younger ages, where a woman who has 2 or more first-degree relatives with breast cancer diagnosed before the age of 50, if she herself is also diagnosed before the age of 50, her risk of contralateral breast cancer at 15 years is actually about 50%. And so all of these factors should come into play when we're counseling our women at increased risk. The impact of family history and age at diagnosis also impacts the risk of contralateral breast cancer in our non-BRCA mutation carriers. This is data from the We Care study. It's a population-based case control study combining data from 5 cancer registries, 4 in the United States and 1 in the Danish group. They identified 700 patients who developed contralateral breast cancer and about 1,400 patients with unilateral breast cancer. All patients were treated from 1985 to 2000. They were all under the age of 54 at diagnosis, and patients with contralateral breast cancer and unilateral breast cancer were matched for birth year, year of diagnosis, cancer registry, and race. And what you see here is that, again, for non-carriers with no family history of breast cancer, the 10-year risk of contralateral breast cancer is actually quite low and under 10% in all age groups. This risk increases slightly for non-carriers with affected second-degree relatives in the second column, but again, those numbers are still less than 10%. And we really don't see these numbers approaching 15 to 20% until we start to look at the non-carriers who have a family history of bilateral breast cancer. And so when we put all this together, again, most of our patients are not BRCA mutation carriers, and most of our patients actually have a 10-year risk of contralateral breast cancer that's less than 10%. Only those patients who have BRCA mutations or those patients that have a family history of bilateral breast cancer in a first-degree relative, those are the groups where the contralateral breast cancer rate exceeds 10% at 10 years. So moving on then, what are the other clinical scenarios where MRI may be useful? Well, occult primary breast cancer, MRI has certainly changed the way we manage these patients. Occult primary breast cancer, again defined as a patient presenting with axillary nodal metastases without evidence of a primary tumor on standard imaging. We know that this is uncommon. It represents less than 1% of all of our cases. But MRI has become a standard imaging tool in these patients and is able to identify the primary breast lesion in over 2/3 of cases. And on the other hand, a negative MRI also provides reassurance that there is not a large tumor burden and that this patient is likely to be treated safely with axillary dissection, whole breast radiation therapy, and appropriate systemic therapy. This is one meta-analysis of 8 retrospective studies looking at just over 200 women with occult primary breast cancer. And in this data set, MRI identified the suspicious breast lesion in about 70% of cases, which translated into a sensitivity of 90% and a specificity of 31%. The mean tumor size in this study ranged from 5 to 16 millimeters, and greater than 90% of the cancers identified were invasive carcinomas. And when MRI identified the occult breast lesion, 20 to 60% of patients were able to undergo successful breast conservation. MRI in Paget's disease. Paget's disease, we know patients present with nipple erythema, erosion, ulceration, and this is due to epidermal infiltration of malignant cells into the nipple. It's associated with an underlying malignancy in greater than 90% of cases, but we know that mammographic imaging may be negative in up to 50% of these patients. And this is one small data set that we published when I was at Memorial. Again, we looked at 34 consecutive women presenting with Paget's disease. Ultimately, 94% of them were found to have an underlying carcinoma, but only 22% of these cases were actually detected on mammographic imaging. And in the subset of our group that had supplemental MRI, among 8 women with a negative mammogram, the MRI detected the malignancy in 50% of cases. It's a small data set, but it's been shown by others in the literature as well that if you are trying to preserve the breast in someone with Paget's disease, that MRI may help you do this. And so moving on a little bit now to the neoadjuvant chemotherapy setting. This is one setting where I think MRI may be helpful in helping us select patients for breast conservation. And this is the challenge that we face from a surgical point of view with neoadjuvant therapy and trying to select patients for breast conservation. We see variable patterns of response within the breast. This, of course, we know depends on tumor subtype, but it's challenging for us to know what to resect and what is the best imaging tool to help us identify what to resect after neoadjuvant therapy. Again, several small data sets suggesting that MRI is probably the most useful tool in helping us to predict residual path size. This is a small study of 31 patients. All of them had mammogram, ultrasound, and MRI before and after treatment. And the MRI predicted response agreed with the pathology response in 71% of cases. And you can see here that MRI was less likely to underestimate and less likely to overestimate the size of the lesion when compared to physical exam, mammography, or ultrasound. And again, I said there are multiple small studies demonstrating the same thing. When these are put together, what we see is that MRI roughly has a sensitivity of about 85 to 90% in predicting the actual residual tumor size, a specificity of about 60 to 80%. This is superior to the other imaging modalities, but we know that this varies by tumor subtype and also by the definition of path-CR used in the studies. And that's highlighted here in this retrospective data set presented by the TBCRC. These investigators pooled data from 8 centers of approximately 750 patients treated with neoadjuvant therapy who had MRI pre- and post-treatment. The overall path-CR rate in this data set was 24%, but the path-CR rate was higher in specific subsets. Triple-negative patients, path-CR was 37%, and HER2-positive patients, path-CR was 38%. And when they looked at the ability of MRI to predict path-CR, we see that in the hormone receptor negative and triple negative groups, MRI had the highest negative predictive value. But it was in the hormone receptor positive groups that MRI had the best positive predictive value. And so again, highlighting the importance of tumor subtype. But across the data sets, this meta-analysis demonstrates what we know, that MRI has a median sensitivity of approximately 90%, a median specificity of approximately 60%, and an overall accuracy of about 88%. Excuse me. And so when I think about using MRI, excuse me, in my patients receiving neoadjuvant therapy, if I know she's already going to have a mastectomy, I do not use MRI. If I know I can already do a lumpectomy, I do not use MRI. But if I am trying to downstage a patient, if I want to take a patient who's a borderline candidate or not a good candidate for breast conservation, if I'm trying to downstage her to a lumpectomy patient, then I will use MRI pre- and post-treatment in those patients to help me determine if this patient is a good candidate for breast conservation. And finally, I'd like to close with the use of MRI as a research tool. These are data from my colleague, Dr. Golshan, who just presented to you earlier. He has performed an Amigo breast conservation study where women with stage 1 and 2 breast cancer eligible for conservation are enrolled. They undergo an investigative MRI, which is actually performed in the supine position as opposed to the normal prone position, and then they undergo standard breast conservation. He performs an investigative MRI after his primary excision and identifies whether there may be residual disease. This is the Amigo suite. You can see very high tech. The MRI is rolled in and out of the operating room. And I think one of the most interesting things that he's demonstrated using this modality is the difference in the tumor between when patients are in the prone position as they are in a standard MRI and the supine position as they are in the investigative MRI in the Amigo suite. And this is shown here with the patient in the prone position. Her tumor is seen in the blue image, and when she's supine, her tumor is seen in the green image. And here are multiple cases demonstrating the difference in the appearance, the size of the tumor, and the position, of course, when the patient is flipped from the prone position to the supine position. And when you look at this across his data set, you see that there's an average tumor displacement of almost 7 centimeters based on the position that the patient is lying in. This, of course, has implications for our treatment planning and certainly implications for the volume of tissue that we would be removing. And I think this is a very interesting and exciting opportunity for us to use this investigative MRI in patients in this supine position to actually really help determine whether MRI can be useful in selecting patients for conservation. And so when that patient asks me, do I need an MRI? My answer is everyone needs high-quality, complete mammogram with or without ultrasound of the breast, but advanced imaging is not indicated in all patients with a new diagnosis of breast cancer. Again, we have no data that routine pre-op MRI improves patient outcomes. We certainly know that MRI can detect contralateral breast cancer, but we see very low rates of contralateral breast cancer developing in most of our patients that we're treating. But MRI screening for the contralateral breast should be considered for those patients at highest risk of contralateral breast cancer. And again, this includes our BRCA mutation carriers, patients with a strong family history of breast cancer, and perhaps those diagnosed at a young age with ER-negative disease. And MRI is useful in certain clinical scenarios: occult primary breast cancer, discordant or complex imaging, Paget's disease, and again, I like to use it when trying to select patients to downstage for neoadjuvant chemotherapy. And I do think it's an important research tool. So, thank you.
Agora a gente vai falar um pouquinho sobre o MA20, o EORTC, né? Quem sabe ele explica para a gente por que o Amaros teve menos linfedema do que esses dois estudos e se serviriam hoje, com nós sabendo todos os subtipos moleculares diferentes que tem em relação a quando esses estudos foram feitos, qual seria a indicação, então, de fazer a radioterapia estendida. Queria chamar a doutora Rina Punglian, please.
Thank you to the conference organizers for the invitation to speak today. Brazil's a beautiful country. I'm excited to be here. So my first topic is radiation of the regional lymph nodes, lessons that we've learned from the MA20 trial and the EORTC 22922 trial. So first, a brief review of the lymphatic drainage of the breast. This slide shows that the drainage from the breast can go in one of two directions. It can go laterally to the axilla and then progress orderly into the infraclavicular and supraclavicular areas, or drainage to the breast can go medially to the internal mammary nodes. Data from lymphoscintigraphy studies show that the first three intercostal spaces are most at risk for harboring internal mammary disease. So the MA20 trial asked the question of whether or not radiation to the regional lymph nodes could be a benefit in women who may be at risk of having subclinical disease in these lymph nodes. These women were defined to be high risk, and high risk was defined as having axillary lymph nodes that were positive on axillary dissection, or having high risk disease but having a negative axillary lymph node dissection. All of the women on the MA20 trial had undergone breast conservation, and they were randomized to either receiving whole breast radiation alone or whole breast plus regional nodal radiation. Patients were stratified based on the number of lymph nodes dissected, the number of positive axillary lymph nodes, and the use of chemotherapy or endocrine therapy. So again, patients who had axillary lymph nodes that were positive after dissection were eligible. Patients who had high-risk node-negative disease were eligible. So these were patients who had tumors that were bigger than 5 centimeters in size, or tumors that were bigger than 2 centimeters in size and fewer than 10 lymph nodes removed on dissection, with any one of the following adverse risk factors, including grade 3 disease, lymph node LVI positivity, or ER negativity. Chemotherapy or endocrine therapy were required. Here are the radiation details for MA20. So the whole breast received 50 gray and 25 fractions. The use of a 10 gray boost was optional. The internal mammary nodes for the women who were randomized to nodal radiation were treated with either partially wide tangents or an anterior field matched to shallow tangents, and the supraclavicular, is this better? Or the supraclavicular and level 3 axillary lymph nodes were treated with an anterior field. This dose to the supraclav was 45 gray and 25 fractions. Here's a schematic of the radiation treatment fields. On the left, we see the patients who were randomized to receiving whole breast radiation alone with tangential radiation therapy. And on the right, we see whole breast radiation therapy with internal mammary lymph nodes included in the tangential field, as well as a separate AP field to treat the supraclav and axillary apex. Here are the baseline characteristics of the women on this trial. Median age was 53. Mean number of lymph nodes removed was 12. About 85% were node positive. About 26% were ER negative. Most patients received chemotherapy, and boost was only given about 1/4 of the time. Here are the 10-year results of MA20. So this trial randomized over 1,800 women. At 10 years, the use of nodal radiation therapy statistically significantly increased local regional control. So without nodal radiation, the risk of having a local regional recurrence was 6.8%, and this decreased to 3.9% with the addition of nodal radiation. Interestingly, the use of nodal radiation also decreased the risk of having distant metastatic disease. So without nodal radiation, the risk of having distant disease in these patients was 16.5%, and this was reduced to 12.9% with a p-value of 0.03. While overall survival was also increased in the nodal radiation group, it was increased only slightly, and this was not statistically significant. So looking at individual subgroup analyses for overall survival, trying to see if there was a group that benefited in terms of overall survival, we see that all the subgroups essentially cross a hazard ratio of 1, showing that there was no specific subgroup. But if you look at ER negative patients, and let me see if I can do the pointer. If you look at ER negative patients here, their confidence interval extends exactly to 1, suggesting that perhaps these patients benefit the most from nodal radiation. But these benefits didn't come without a cost. Any lymphedema increased from 4.1% to 7.3% in the nodal radiation group. Muscle weakness also increased from 1.1% to 2.5% in the nodal radiation group. And radiation pneumonitis was also increased from 0.2% with tangential radiation alone to 1.3% with the addition of nodal fields. All of the pneumonitis was grade 2, however. So the EORTC also conducted a similar trial. This was the 22-922 trial, randomizing over 4,000 women who had stage 1 to 3 breast cancer, who had either axillary lymph node positive disease or node negative with central and medial cancers, to receiving no nodal radiation, or the arm which received both internal mammary and supraclavicular radiation therapy. Here are the patient characteristics of this trial, which accrued between 1996 and 2004. Median age was quite similar at 54. Results were reported at a median follow-up of almost 11 years. 60% of the cancers were T1. In fact, 1/4 of these patients underwent mastectomy, and systemic therapy was used for 85% of these patients. And here are the 10-year results with or without nodal radiation therapy. So again, interestingly, nodal radiation improved distant disease-free survival from 75% without nodal radiation to 78% with nodal radiation, and this was statistically significant. Disease-free survival was also improved from 69% to 72%. And again, overall survival was slightly increased in the nodal radiation arm, but not statistically significantly so. So taken together, both MA20 and the EORTC trials do support comprehensive nodal treatment. However, they do leave behind some unanswered questions, such as who benefits the most from nodal radiation therapy? Is it women with 1 positive node, 4 positive nodes, 1 to 3 positive nodes? And because both of these trials included both the internal mammary and supraclavicular fields, we don't know the relative benefit of treating each of these fields individually. Do we need to treat both, or is one of these fields getting us most of the benefit? So to answer these questions, we can go back to some other analyses. This is the Oxford overview published by the EBC-TCG, looking at 22 trials of over 8,100 women treated with mastectomy plus axillary surgery, randomized to receiving post-mastectomy radiation therapy or not. Adjuvant systemic therapy was used in the majority of these patients, and radiation, when it was given to the patients who were randomized to receive it, was radiation to the chest wall, supraclav, plus or minus axilla, but also the internal mammary nodes. Here are the results from the Oxford overview, separating out the outcomes for patients with 1 to 3 positive nodes on the top and those with 4 or more positive axillary nodes on the bottom. And you can see here that even for the patients with 1 to 3 positive lymph nodes, the addition of post-mastectomy radiation therapy improved local regional recurrence, any first recurrence, and also breast cancer mortality. When further trying to split up the benefit between patients with 1 positive node versus patients with 2 or 3 positive nodes, we can see that again here, patients with 1 positive node had a benefit in terms of mortality from breast cancer and any first recurrence. So they're the top box seen in each of these graphs. So the meta-analysis of the post-mastectomy radiation trials shows that even with systemic therapy, post-mastectomy radiation therapy reduced any recurrence and improved breast cancer mortality in node-positive patients, even those who had only 1 positive lymph node. Although this is not clear if these findings would hold true with more modern systemic therapy, including targeted agents. And what about the internal mammary nodes? Do we really need to be treating them? So extended radical mastectomy series where the internal mammary nodes were resected have shown that the location and the size of the primary tumor in the breast, as well as the extent of the involvement in the axilla, predicts for internal mammary involvement. So this incidence can be as low as 5% in patients who have lateral axillary lymph node negative cancers, but can be as high as 40% in patients who have medial or central breast cancers who have axillary positive lymph node disease. But despite the relatively high rates or high likelihoods of internal mammary nodal involvement in these extended radical mastectomy series, modern mastectomy series have shown that the rates of having an internal mammary nodal recurrence are actually quite low. Generally, 2% of our patients or fewer have internal mammary nodal recurrences. This is likely an underestimate of the true recurrence rate, as the intrathoracic location of these nodes would make detection of this recurrence or could make it quite difficult. So is there a benefit to internal mammary nodal radiation therapy? One study to specifically look at this question was done in France. It was a multi-center randomized trial, which randomized over 1,400 women and reported results at a median follow-up of 11 years. These patients could have axillary lymph nodes that were positive or have negative axillary lymph nodes as long as they had medial or central cancers. Patients received chest wall and supraclavicular radiation and then were randomized to receiving either internal mammary nodal radiation or not. For the patients who were randomized to receiving internal mammary radiation, the first 5 interspaces were included, and 2/3 of this dose was delivered with electrons. Here are the key patient characteristics on the French study. So about 2/3 of these cancers had medial. 2/3 of these patients had medial cancers. About 3/4 were node positive. About half received chemotherapy, and about half received hormonal therapy. And looking at overall survival, we see no difference in terms of overall survival, whether or not internal mammary nodal radiation was given. However, to power the study for an overall survival benefit was highly optimistic, given that in the Oxford or the EBC-TCG overview, there was only a 5% difference in overall survival, and that's with post-mastectomy radiation therapy versus no radiation. Here we're only randomizing to internal mammary nodal radiation versus no internal mammary nodal radiation. So although this is a negative study in terms of overall survival, it could have been expected that this would have been a negative study. So more data about whether the internal mammary nodes need to be treated or not does come from the Danish experience. And this publication is a prospective cohort study of patients enrolled between 2003 and 2007. All of these patients had node-positive disease and were younger than the age of 70. All of these patients received periclavicular and chest or breast radiation therapy. But interestingly, per Danish guidelines, left-sided cancers receive radiation therapy without internal mammary nodal radiation, given the proximity of these nodes to the heart, whereas right-sided cancers did receive internal mammary nodal radiation. So this provided a natural experiment with which to study the benefit of internal mammary nodal radiation. So again, with the median results were published with a median follow-up of 7 years. Median age was 56. 2/3 of these patients received mastectomy. 80% were ER positive, and almost all patients received adjuvant systemic therapy. So what's interesting about this study is that overall survival did increase with the addition of internal mammary nodal radiation versus without it. So the right-sided patients were doing better in terms of overall survival relative to the left-sided patients. Deaths from breast cancer did decrease with the addition of internal mammary nodal radiation as well. And in this study, there was no increase in terms of deaths from cardiac disease. So coupled with the MA20 and ERTC data, we have these data, the EBC TCG showing us that comprehensive nodal radiation is a benefit, although this meta-analysis did lack modern chemotherapy and doesn't tell us which fields are necessarily the most important. We have the French study, which tells us, which is the purest of the internal mammary nodal studies, but it was negative, but it was also underpowered. And we have the Danish registry study, which is very compelling, but wasn't a randomized trial. So again, with MA20 and EORTC, we are treating more internal mammary nodes in our practice, and the bar is dropping with respect to treating the internal mammary nodes. So how do we do this? So first, looking at the supraclavicular and axillary field, we contour out the level 1, 2, and 3 lymph nodes and treat APPA, paying attention to homogeneity. But here is where we run into problems. If we want to treat the internal mammary nodes on this patient, you can see how close her heart is, especially the left-sided internal mammary nodes, would lead to significant cardiac radiation. And the problem with radiating the heart is we have data now from the Darby study, which looked at over 2,100 women who underwent radiation in the 60s and to 2001 in Sweden and Denmark. And this was a case control study looking at patients who, after radiation, had a major coronary event versus controls that didn't. One of the issues with this study is the patients were enrolled before the CT simulation era. So radiation dosimetry was determined from radiation charts, and virtual simulations were conducted based on a CT scan of a patient with typical anatomy, which may or may not be accurate for an individual patient. So patient charts were obtained, and they were used to reconstruct the radiation fields and estimate doses to the structures of interest, including the heart and the LAD coronary artery. The major findings from the Darby study was that coronary events increased linearly with mean heart dose. And while most of this excess cardiac risk was present within 10 years of receiving radiation therapy, some of this excess risk was present even after 20 years from receiving radiation therapy. In addition, pre-existing cardiac risk factors led to greater absolute increases in cardiac risk from radiation therapy. So here is their main graph showing that on the x-axis, mean dose of radiation therapy to the heart, and for each increase in gray of mean dose to the heart, we have a 7.4% increase in the relative risk of having a major coronary event. One of their major conclusions from this study was that there was no threshold, so there didn't look to be a dose below which it was safe to give cardiac radiation therapy. In fact, the dose, the risk increased linearly from 0. So translating these into absolute increases, here is what you might find for a 50-year-old woman based on the study. If her mean cardiac dose is 3 gray, which is pretty typical if we're treating the internal mammary nodes, If she has no cardiac risk factors, her risk of having a radiation-related ischemic heart disease death is 0.5%. And if she does have risk factors, her increase in risk is actually 0.7%. And while these numbers are small, the benefit in terms of treating the internal mammary nodes may also be small, so they need to be weighed individually for each patient. So what can we do to actually improve our numbers in terms of cardiac dose and still be able to treat the internal mammary nodes? So one thing that we've been doing routinely for our left-sided patients is deep inspiration breath hold technique, where we treat only in the deep inspiration phase of the respiratory cycle. And we can see here that for most women, when they take a deep breath in, the heart actually moves away from the chest wall. And here's a little movie of a CT sim where a patient with implants after mastectomy is taking a deep breath in, and you can see how it's much easier to treat in the deep inspiration phase of the respiratory cycle with respect to cardiac dose. So when a woman does take a deep breath in, what we can do is we can contour out the first 3 interspaces. We open up the tangents to include the internal mammary nodes, and then block inferiorly where the heart gets closer to the chest wall. So in conclusion, we have growing evidence for the benefit of regional nodal radiation. However, long-term toxicity may not yet be apparent, especially with respect to the lung, the hearts, and possibly even secondary malignancies. So we do need to minimize the dose to the heart and lung in those that we do treat with nodal radiation, and we need to weigh the risks and benefits of treating the internal mammary nodes individually for each patient. Thank you.
I'd like to invite all speakers to come here, please. And, por favor, Dr. Carlos Chimizo e Dr. Antônio Carlos Jardim. Bom, queria então pedir para os debatedores começarem, por favor. Carlos, pode ser você?
Sim, bom dia a todos. Agradeço à comissão organizadora pelo convite. Eu sou um radiologista especializado em mama e trabalho praticamente com isso agora. Eu queria fazer uma pergunta para o Dr. Merzla Goslan. Se nesses casos que você apresentou...
Um minuto só. Are you listening?
Tá certo? Tá escutando? Ok. Eu queria saber se no seu serviço vocês fazem biópsia de linfonodo sentinela para as pacientes que são submetidas a mastectomia profilática redutora de risco.
So I think that's a terrific question. In our group, and at least in my practice, I do not do any form of lymph node evaluation for someone undergoing prophylactic mastectomy who's had appropriate imaging workup prior to surgery. I know there's some controversy in the literature on this, but I think most of the data suggests that if you've worked these women up with mammogram, MRI, there's no abnormality seen, that the risk of finding a cancer is low, and then the risk of actually finding a cancer that has lymph node involvement is, vanishingly low. I don't know, Terry, if you're thinking similarly or not.
Yes, so in my BRCA mutation carriers who are considering prophylactic mastectomy, we frequently have been monitoring them with mammograms and MRIs. And if I have a patient who's had a negative MRI in the 6 months leading up to the time that we're doing the surgery, then I do not perform sentinel lymph node biopsy. The data, again, suggests that in that group, if you've had a negative MR within 6 months, the likelihood of that patient having an occult invasive cancer is about 1%. The likelihood of that patient having an occult DCIS is about 4 to 5%. So you really don't, in my opinion, don't need to do routine sentinel node biopsy in patients with negative MRs. But if there's anything on the MR, even if it's a BIRADS 3 6-month follow-up recommendation, then I will do a sentinel node in that high-risk population.
Aproveitando o que a doutora Terry King comentou, eu queria perguntar se numa situação onde a paciente ela passe com você pela primeira vez, né, uma paciente de alto risco ou com mutação de BRCA, e essa paciente ela deseje fazer uma cirurgia profilática redutora de risco, uma mastectomia redutora de risco, se nesse caso, antes de submeter a paciente à cirurgia, você faz a ressonância magnética.
So the question is, the imaging done prior to the risk-reducing mastectomy, we would get an MRI, correct?
Yes.
But I don't know if I heard it correctly. And I'd want that done within, 6 months, but probably even preferably within 3 months of undergoing the procedure.
So my question was about if the patient come for the first time to you and you don't have the chance to ask for a breast MRI, or you don't have prior exams, or she wants immediate surgery.
Well, if she wants surgery and she's a BRCA mutation carrier, and there's nothing that's concerning on exam, I would certainly try to work her up prior to undergoing the risk-reducing surgery. And again, even though I think maybe the other way of looking at this is that even though the risk of sentinel lymph node biopsy is low for developing lymphedema, it's not zero. And no matter how great the surgical technique is, anywhere in the literature between 2 to 7% of the time, she could develop lymphedema. So if I could avoid that risk, I will. And if I have the luxury of time of working them up prior to surgery, which we usually do because by the time they meet with us and the reconstructive surgeon and make that decision on the type of surgery, that we would be able to get the appropriate imaging beforehand.
Yes, I agree, and particularly in the setting of a patient who's having breast reconstruction, you don't want to be surprised by a malignancy that you weren't aware of and have a patient having gone through a big reconstructive procedure and now facing either returning to the operating room to assess the lymph nodes or being left in a situation where you now can't perform a sentinel node biopsy and you're having to perform an axillary dissection to assess the lymph nodes.
Eu tenho mais uma pergunta para a doutora Terry King. Nos casos de pacientes, sobre ressonância pré-operatória para estadiamento de câncer de mama. Se nesses casos, vários estudos mostraram uma associação entre ressonância magnética e aumento de mastectomia. Né? E eu queria perguntar para ela se, eventualmente, essa associação pode estar relacionada ao fato de que as pacientes que fazem ressonância magnética no estadiamento pré-operatório são pacientes jovens, pacientes com história familiar, pacientes com lesões histológicas mais agressivas. Né? E de início, isso já induziria ao cirurgião a indicar mastectomia para essas pacientes e não ser, de fato, a ressonância magnética.
So we do see MRI being ordered by physicians in those patients that they are concerned about their risk, such as the young patient, the patient with strong family history, perhaps patients with ER-negative disease. So physicians sort of are biased in selecting to use MRI in patients that they're concerned about a genetic or hereditary predisposition with or without an actual mutation being identified. But the data does not suggest that those women are better treated by mastectomy. And so I think we have to be very careful when we use MRI in the preoperative setting the additional disease that may be identified certainly can change treatment plans in a small number of women in an appropriate way. But most of the time, if there is disease identified, it's disease that could still be managed with a conservative approach. But by introducing the idea that there may be more there than we originally saw, or as in the example that I've shown, subjecting women to additional biopsies for false positive findings, these tend to lead to an increased level of anxiety among our patients, and our patients tend to lean towards or choose more aggressive surgery, even if it may not be necessary based on the disease presentation. So while I agree with you, there are some times when we may want to use the MRI to provide reassurance to ourselves or reassurance to our patients that they are good candidates for breast conservation. We have to be very careful because, again, the data show no difference between mastectomy or breast conservation. In young patients, ER-negative tumors, there's no benefit to mastectomy. So we need to be careful when we're using this imaging that tends to create, again, more procedures and more anxiety, and tends to sway women into thinking that they might need bigger surgery when the data would suggest that they don't.
Por favor, Dr. Antônio Carlos.
A minha pergunta para a doutora Rina é, tanto o estudo MA20 quanto o EORTC 22922 mostraram uma melhora nas taxas de sobrevida livre de doença de 5% e 3%, respectivamente. Entretanto, não houve nenhuma alteração nas taxas de sobrevida global e houve um aumento na incidência de complicações importantes, como linfedema, de 4,5% para 8,4% e fibrose pulmonar, de 1,7% para 4,4%. Nós sabemos que a totalidade dos pacientes do estudo MA20 e a imensa maioria dos pacientes incluídos no EORTC não fizeram uso de taxanes. O trial B27 do NSABP mostrou uma redução em torno de 40% de comprometimento linfonodal naquelas pacientes que fizeram uso de taxanos, e um aumento também na sobrevida global. Aí eu lhe vou fazer uma pergunta aqui de cunho filosófico. Partindo do princípio em que fazer radioterapia em cadeias periféricas não altera a sobrevida global, aumenta a incidência de complicações graves e, ao mesmo tempo, foram feitos numa época em que não se usava as drogas que nós temos hoje, que sabidamente melhoram a sobrevida global e a sobrevida, a redução de recidivas locais, é válido fazer radioterapia em cadeias periféricas nesse momento?
No, I think that's a great question, and you're absolutely right that as systemic therapy is changing, the relative benefit of radiation therapy may also be changing too. The issue is that, you know, we don't know where exactly we are in terms of once the trial is done. The systemic agents that we've used are, you know, older systemic agents. They may not have included the taxanes, as you point out. And so once the trial's done, we're already kind of behind the 8 ball. But one thing to keep in mind as well is that as systemic agents are getting better, we may actually be isolating patients who may otherwise have been doing worse, and in those patients, actually, radiation therapy might be more important. It depends on where you are along the continuum of, is systemic therapy so good that you don't need radiation anymore? Is it so bad that you actually, radiation's not going to be of any benefit? Or are we in that middle range where even with very good systemic therapy, radiation therapy could be more important? But you're right, there are downsides to treating, and that's why we need to do this on a case-by-case basis and be very careful about treating the heart and the lungs, especially if we're going to be adding nodal radiation.
Tem mais alguma pergunta? Eu queria fazer uma pergunta. Uma paciente de 24 anos com um tumor unilateral, triplo negativo, e que desejava engravidar e amamentar no futuro. Ela fez uma mastectomia unilateral e um tratamento adjuvante. Eu queria saber se vocês indicariam tamoxifeno para essa paciente até ela desejar engravidar no futuro.
I thought you said she had triple negative.
Sim.
So
Yes.
tamoxifen would not be indicated in a patient with triple negative breast cancer for treatment of her tumor. So she wouldn't get any benefit, any survival benefit from the tamoxifen in a triple negative case.
Em relação à mama contralateral, em termos de prevenção, existe alguma indicação? Porque ela manteve a outra mama.
So we would tend not to use tamoxifen for contralateral risk reduction in a woman whose index cancer was ER negative. The data would suggest that if a woman's first cancer is ER negative, that the overwhelming majority of contralateral disease will also be ER negative. So I would not recommend tamoxifen for risk reduction in someone with an index triple negative breast cancer.
E eu queria fazer mais uma pergunta para a doutora Rina Puglia. Qual a explicação ou qual a sua opinião em relação aos índices de linfedema? O MA20 e o RTC mostraram um índice de linfedema bem importante, enquanto o trabalho holandês, o Amaros, mostrou um índice de linfedema ínfimo. Como a senhora pensaria nessa diferença de resultados, ou explicaria?
Can you say that again? You're saying that lymphedema increased
Em MA20 e ORTC
20.
and decrease in Amaros.
And so we'll talk about Amaros, but coming up in the afternoon. But Amaros didn't have full axillary surgery. Amaros only had sentinel lymph node biopsy, so that's probably the difference between rates of lymphedema in the MA20 and EORTC versus Amaros.
Ok. Alguém da plateia quer fazer alguma pergunta? Ali? Minuto só. Chega no microfone.
Oi, eu queria perguntar para a doutora Terry se essas mudanças de conduta baseadas na ressonância, tanto como numa neoadjuvância ou num planejamento cirúrgico de primeira linha, tem impacto na sobrevida dessa paciente ou é mais uma questão cirúrgica mesmo? Se tem algum dado que permite dizer que a mudança de planejamento cirúrgico a partir da ressonância teria um impacto na sobrevida da paciente?
Thank you. So there is absolutely no data showing that the use of MRI impacts either short-term or long-term outcomes. So no data that MRI leads to better treatment that leads to improved survival. We also know that there is no difference in survival between women undergoing breast conservation and women undergoing mastectomy, right? So survival is really predicted more by the biology and by the effectiveness of our systemic therapies. So we need to select our patients well for conservation, and we need to perform mastectomy when it's necessary. But we need to recognize that MRI is not the tool to help us make that decision, and that whether a breast cancer comes back or not has the same likelihood whether you do a lumpectomy or whether you do a mastectomy, because it's really predicated on the biology, not the surgery.
Bom dia. Eu queria perguntar para o Dr. Merhan A respeito da abordagem axilar. Depois do Z011, nós temos visto muita extrapolação na conservação da axila, além do que o Z11 mostrou. O Z11 foi um estudo elaborado com uma idade média das mulheres de 56 anos, a maioria dos tumores eram T1, boa parte dessas pacientes tinham um excelente prognóstico. Nós temos visto, mundo afora e aqui no Brasil também, uma extrapolação desses dados para a conservação axilar. Queria saber o que o senhor acha disso. Se nós temos hoje dados suficientes para extrapolá-los.
So you're talking about Z11 versus the MA20 trials. So we'll be talking about Z11 this afternoon, but you're right. On average, patients on the Z11 trial did have lower risk disease than the patients on the MA20 trial, and so we'll try to figure out how to tease out which patients should be getting only tangential radiation or high tangents versus full axillary radiation. But it has to do with levels of risk, the likelihood of having residual positive nodal disease in the axilla.
Ok, então... Ricardo?
A minha pergunta para a doutora Rina é: com uma certa frequência no Brasil, nós temos visto pacientes que são candidatas à cirurgia conservadora serem tratadas com skin sparing e nipple sparing mastectomy, em vez da cirurgia conservadora. A minha pergunta é: quão confortável você fica com uma moça na pré-menopausa, triplo negativo ou HER2 positivo, que seriam candidatas para radioterapia se fosse uma cirurgia conservadora, quando são tratadas com skin sparing e nipple sparing, em não fazer radioterapia?
So guidelines for post-mastectomy therapy.
No, not post-mastectomy. Do you consider skin and nipple sparing mastectomy the same as mastectomy?
It's a good question. So yeah, if the margins are negative, we do consider them the same. So we won't necessarily treat patients just because they had a nipple-sparing mastectomy or skin-sparing mastectomy.
One, I guess, caveat is who's doing the skin and nipple sparing mastectomy. We have seen cases where there is a significant amount of residual breast tissue that's left behind. So certainly I would say that when you're comparing just a simple mastectomy to skin and nipple sparing, you're under the assumption that the oncologic procedure was done in a similar fashion.
Ok, então vamos dar por encerrado esse módulo e agora é a hora do intervalo.